I want to start with a statistic that I found in our research stack that, honestly, it made me stop and just reread the page.
Oh, yeah.
We all kind of accept this rule, right? Diabetes is bad news for your long-term health. It's
Ah.
metabolic chaos. It's linked to a higher risk of liver cancer, pancreatic, breast cancer. The list is long and, frankly, depressing.
Right, that's the standard medical narrative. High sugar, high insulin equals high risk.
Exactly. But then you look at the data for prostate cancer, and paradoxically, having diabetes is actually associated with a lower risk of developing it.
It creates a massive cognitive dissonance, doesn't it? It just completely breaks the rule.
It does. And it forces you to realize that the relationship between our metabolism and cancer isn't just a straight line. It's messy. It's incredibly complicated.
It is messy, and that messiness is exactly what we're wading into today. We're exploring what researchers are calling this twisted bond between metabolism, aging, and cancer.
And just to set the stage for you, we aren't just talking about watching your blood sugar. We're going much deeper into the real machinery of the body. We've got a stack of sources today that feel like a glimpse into the future.
We do. We've got a major review on how anti-diabetic drugs interact with cancer, and then two heavy-hitting presentations from the 2025 Aging Research and Drug Discovery Conference.
One by Dr. Miriam Marad on the immune system, and another by Dr. Nathan Lebrasseur on biological aging markers.
And if we connect the dots between these three sources, which is really our mission for this deep dive, a very clear picture starts to emerge. It's a story about maintenance.
Maintenance, yeah.
It's about how your metabolism, your immune cells, and your body's ability to take out the cellular trash all conspire to either keep you healthy or, roll out the red carpet for a tumor.
The aha moment for me was realizing inflammation isn't just a symptom that happens after you get sick. It's actually a trigger.
That is the crux of it.
It's the difference between a harmless mutation and a deadly disease.
That's the concept of the second hit, which we will definitely get to. But before we get to the solution, we have to understand the problem, the environment that allows that hit to happen in the first place.
Okay, so let's start with the metabolic side. We're looking at this huge review on type 2 diabetes. And the sources make it clear. Type 2 isn't just high sugar, it's an entire ecosystem, isn't it?
That is the perfect word for it, an ecosystem. When you have type 2 diabetes, yes, you have hyperglycemia, high sugar. But you also usually have obesity, insulin resistance, and this chronic low-grade inflammation.
And this all creates what oncologists call the TME, the tumor microenvironment.
Exactly, TME. It sounds like a bad place to be because it is.
Right.
Think of it as the soil. If the cancer cell is the seed, the TME is the fertilizer. This environment damages DNA, but worse, it promotes angiogenesis.
Angiogenesis, that's the growth of new blood vessels.
Right. Precisely. It's literally building the highways to feed the tumor. So the question the review asks is, when we use drugs to treat diabetes, are we just lowering a number on a glucose meter, or are we actually remodeling that soil?
Are we changing the TME?
Exactly.
Which brings us to the drug cabinet. Let's talk about the old guard first, metformin.
I feel like everyone knows someone taking metformin. It's like the aspirin of the diabetes world.
It's one of the most widely prescribed drugs in history.
Yeah.
And for a long time, the thinking was pretty simple. Okay, it lowers glucose so it starves cancer of fuel.
Simple logic.
But this review highlights that metformin is doing something much more sophisticated. It activates the AMPK pathway.
Okay, let's unpack AMPK. We hear this acronym a lot in longevity circles. What's it actually doing?
Think of AMPK as the master fuel gauge, or maybe the energy switch for your cells. When metformin flips that switch, it tells the cell, hey, we're low on energy. It creates a simulated energy crisis.
Like a fast. Very similar to fasting, yeah. And when a cell thinks it's running out of energy, what does it do? It stops spending resources on expensive projects, like dividing.
It's not cycle arrest.
Right. But it doesn't stop there. It also seems to wake up the immune system, specifically the CD8 plus T cells.
Those are the soldier.
The hunter killers. They find the cancer cells and destroy them. So metformin stops the cancer from growing, and it calls in the cavalry.
That sounds like the perfect drug. Why isn't everyone on it?
Well, in many cases, it is fantastic. The data shows it's generally protective against liver and colorectal cancer. But, and here is where biology gets humble, there is conflicting evidence.
Oh.
The review points out studies suggesting metformin might actually increase the risk of certain types of breast cancer, specifically the ER-positive one.
Hey, really, that seems so counterintuitive.
Yep.
If it's starving cells, why would it help one type of cancer grow?
I mean, it comes down to how incredibly messy these signaling pathways are. While metformin is shutting down one energy pathway, it might be inadvertently altering hormone receptors, like the estrogen receptor, in a way that benefits that specific tumor.
Wow,
It's just a stark reminder that there's rarely a magic bullet that works the same way everywhere.
that is wild. Okay, let's move from the old guard to the new celebrities. GLP-1 agonists. Drugs like Ozempic, Wegovy, everyone's all talking about them for weight loss, but this material suggests they might be doing something fascinating for cancer prevention too.
This was one of the most surprising parts of the review for me. We know these drugs help with weight loss, and losing fat is cancer protective in itself. Fat tissue is inflammatory.
Right.
But these drugs also seem to directly shift the behavior of macrophages.
Macrophages, those are the immune cells that eat up debris, right? The big eaters.
Roughly, yes. But they have personalities, if you will. You have the M1 phenotype, which is inflammatory and aggressive. Think of them as the SWAT team, kicking down doors.
Yeah.
And then you have the M2 phenotype, which is more like the construction crew repairing tissue, cooling things down.
And we want the construction crew.
Usually, yes. GLP-1 agonists seem to shift macrophages from that bad M1 inflammatory state to the good M2 repair state. You're essentially telling the immune system to put down its guns and pick up a hammer.
That sounds fantastic for reducing inflammation. But I have to play devil's advocate. I remember seeing headlines a while back about thyroid cancer risks with these drugs. Does the source tackle that?
It does, and it tackles it head on. It's a classic case of mice are not men. In rodents, these drugs cause the C cells in the thyroid to proliferate like crazy, which leads to tumors.
But we aren't big mice.
Exactly. Human C cells simply don't have the same density of GLP-1 receptors. The biology is different. So while the rodent data looks scary, the human data is, well, it's conflicting. Some studies show no increased risk at all. Others show a faint potential signal.
So something to watch.
Oncologists are watching, but it's not the panic button the headlines made it out to be.
Got it. Okay, what about the third class? SGLT2 inhibitors. These are the ones, correct me if I'm wrong, that basically make you pee out excess sugar.
That's the mechanism. You dump glucose into the urine. By doing that, you are starving the tumor of its favorite fuel. But they do something else that's arguably cooler. They induce autophagy.
Autophagy. Self-eating.
It's the cell's internal recycling program. It cleans out damaged proteins, organelles. By ramping that up, SGLT2s can help clear out the cellular garbage that can eventually lead to cancer. But bringing it back to your intro.
The twisted bond.
The twisted bond
Yeah.
appears here too. The prostate paradox.
Right.
While SGLT2s seem to reduce overall cancer risk, there is some data linking them to a potential uptick in prostate neoplasms.
It's just baffling. Why the prostate?
We don't fully know yet. It just highlights that when we manipulate metabolism, we are pulling on a very complex web. You pull a string to fix the kidney, and something vibrates in the prostate.
And speaking of pulling strings, we have to mention insulin itself. If you're diabetic, you might be injecting it. And isn't insulin basically a growth hormone?
It is anabolic. High insulin levels promote growth via IGF-1, which can absolutely fuel tumors. However, the review is careful to point out a crucial distinction.
Okay.
Therapeutic insulin, the stuff patients inject, doesn't seem to increase overall cancer risk in the same dramatic way that the body's own skyrocketing insulin does during early type 2 diabetes.
So treating the diabetes is still the safer bet.
Absolutely. The chaotic environment of the untreated disease is far more dangerous than the treatment.
Okay. So we've established these drugs are doing double duty. They're managing sugar, but they're also tweaking our immune system and inflammation. I want to pivot now to that second source, Dr. Miriam Murad's presentation, because she dives straight into this idea of immune dysfunction. She uses a phrase I loved, the betrayal of the immune system.
Betrayal is dramatic, but it's accurate. She introduces us to the concept of inflammaging.
Which is just a great word.
It really is. It describes how, as we age, our baseline level of inflammation just creeps up, even if we aren't sick. And Murad argues that macrophages, those cells we just talked about, are the conductors of this orchestra.
We touched on macrophages, but she goes deeper. She distinguishes between two types that I found really helpful for visualizing this.
Yes. She talks about tissue-resident macrophages versus monocyte-derived macrophages. Let's use an analogy.
Okay.
Think of tissue-resident macrophages as the guardians. They live in your organs, your lungs, your gut, from the time you're an embryo. They know the building, they maintain the tissue, repair damage, and keep the peace.
So they're the original staff, the expert.
Exactly, the architects. But here's the problem. As we age, we lose them. Their numbers decline significantly. And nature abhors a vacuum, so they get replaced by monocyte-derived macrophages.
Oh, cool.
These come from the bone marrow. They are new recruits, and they are not architects.
They're the demolition crew.
They are. They're aggressive, inflammatory by nature. They shoot first and ask questions later. So as you get older, your maintenance staff is replaced by a SWAT team. And Murad's lab asked, why? Why is this happening? And they found a metabolic link.
Polyamines.
Polyamines. It sounds like a synthetic fabric.
It does, doesn't it?
Yeah.
But they are actually these ancient molecules, essential for cell growth. And Murad's team found that the synthesis of polyamines just drops off a cliff in aged cells. The Guardians basically starve without it.
And this leads to the mouse experiment, right? The spermidine insight.
Correct. They asked, what if we just give the fuel back? They supplemented older mice with spermidine, a compound that boosts polyamine levels. The results were striking. It restored the population of those good tissue-resident macrophages.
Did it actually make the mice healthier, or did it just look good under a microscope?
Oh, functionally it mattered. The older mice who got the supplement were able to fight off infections, like pneumonia, just as well as young mice. It reversed the immune decline. That is incredible, just by replenishing one molecule. But here's where it gets really scary and really interesting. Murad talks about the second hit theory. This is the part that gave me chills.
This is so crucial for understanding cancer prevention. For a long time, we focused entirely on the mutation, the genetic error, the seed.
We thought if you have the mutation, you get the cancer.
Exactly. But we now know that's not true. Many of us are walking around with cancer-causing driver mutations in our healthy tissue right now.
Wait, so I might have a mutation for lung cancer in my lung right now, but I don't have cancer?
Almost certainly. Murad cites Charlie Swanton's work on this. The mutation is the first hit. It's the match. But a match is useless without fuel. The second hit, that's the inflammation.
Often driven by those aggressive bad macrophages we just discussed.
Yes, so the mutation sits there dormant, harmless, until inflammation comes along and wakes it up.
And the evidence for this is compelling. She mentions the Novartis trial, the CANTUS trial.
This is a famous story. It was a huge study testing a drug that blocks IL-1 beta, a major inflammatory signal.
But they weren't testing it for cancer, right?
No, it was a heart disease trial. They wanted to see if lowering inflammation prevented heart attacks. But when they looked at the data, they found something accidental and profound. The people on the high dose of the anti-inflammatory drug had a massively lower incidence of lung cancer.
That is mind-blowing. They weren't treating tumors.
They were just cooling down the inflammation. And here's the kicker. It stopped the cancer from starting. If a patient already had a tumor, the drug didn't help much. It proves that inflammation is the trigger.
The second hit.
Once the fire is raging, removing the match doesn't put it out. But if you remove the match early, the fire never starts.
That completely changes how we should think about prevention. It's not just don't smoke, it's keep your inflammation low.
Correct. You have to manage the soil.
Which leads us perfectly to our third source. If inflammation causes all this damage, how do we measure it? How do I know if I'm inflammaging right now? That's where Dr. Nathan Lebrasseur comes in.
Right. Lebrasseur focuses on the aftermath of that damage, in essence.
Zombie cell.
The zombie cells. These are cells that have stopped dividing, usually because of DNA damage or stress, but they refuse to die. They just linger.
And they aren't just sitting there quietly, they're active.
That's why zombies is such a good descriptor. They are actively harmful. They secrete this toxic cocktail of inflammatory factors called SSP.
Senescence-associated secretory phenotype.
Exactly, SSAP. And Lebrasseur points out that these cells pump out hundreds of times more inflammatory gunk than a normal cell. It's like a scream for help that never ends.
So one zombie cell can poison the whole neighborhood.
It can. They try to recruit the immune system to kill them, but because the immune system is aging, like Murad showed us, it can't clear them out efficiently. So they build up. And Lebrasseur asked a simple question: can we measure this SASP in the blood? Can we quantify the zombie burden?
And the answer seems to be yes. He talks about this study with a massive biobank, 57,000 people.
This was a standout moment. They looked at a subset of healthy 65-year-olds. They measured these SASP proteins in their blood, and they found that these markers were better at predicting who would die in the next few years than chronological age, sex, or even race.
That is staggering. Biological age over chronological age.
Yeah.
It's not how many birthdays you've had, it's how much inflammatory gunk is in your blood.
It is. But the stat that really hit me, the one that underlines why this matters for cancer, was about ovarian cancer.
Oh, I remember this.
He showed data for women diagnosed with it. Those who had the highest levels of these zombie cell markers at baseline before treatment had only a 10% survival rate after 5 years,
10%.
compared to 70% for those with the lowest markers.
Wow. Same disease, different soil.
Exactly. It dictates your resilience. If your body is already fighting a full-scale war against these senescent cells, it has no resources left to fight the cancer. You're starting the marathon with a broken leg.
But Lebrasseur offers some hope. These markers aren't set in stone.
No, they're modifiable. He referenced the calorie study on caloric restriction. When healthy people reduced their calorie intake by just 12% over 2 years, those toxic markers went down.
So lifestyle actually helps clear out the zombies.
It seems to dampen their activity, yes. And then there's the emerging field of senolytics drugs designed to specifically kill these cells. Lebrasseur mentioned a trial using dasatinib and quercetin, and the biomarkers helped show who was actually responding to the drug.
It's like a sniper approach instead of a carpet bomb.
Precisely.
So let's bring this all together. It feels like we have a complete narrative here. From the drugs to the immune system to the zombie cells. How do you synthesize this?
Okay, think of it as a domino effect. It starts with metabolic dysfunction, from diabetes, obesity, poor diet, like we saw in the first source, this metabolic stress. It stresses your immune system. That leads to the shift Merad described. The good guardian macrophages die off, and the bad demolition crew moves in because they lack the right fuel.
Which creates the inflammation.
Exactly. That inflammation acts as the second hit, triggering those dormant mutations. At the same time, all that damage creates senescent zombie cells, which pump out more inflammation, the SASP.
Creating a vicious feedback loop that Lebrasseur can measure in our blood.
It's a self-perpetuating cycle. Metabolic stress, inflammation, zombies, cancer.
And that is why the twisted bond exists. It's not one thing. It's the collapse of the maintenance system.
That's it.
So what does this mean for us, for the listener? It sounds like we're on the cusp of a totally new way of practicing medicine.
We're moving toward an era of what I'd call precision prehabilitation.
Precision prehabilitation. I like that. Unpack it for me.
Right now, we treat cancer when we see a tumor. We wait for the fire. But this science suggests we should be treating the host. Imagine a future where you get a blood test at age 45 or 50. It doesn't look for a tumor. It looks for Lebrasseur's zombie markers.
And if they're high?
We intervene. We don't wait for cancer. Maybe we prescribe a metabolic drug like metformin. Maybe we use an anti-inflammatory like that IL-1 beta blocker to stop the second hit. Or maybe we use a senolytic to clear the zombies.
We cool down the system before the disaster happens. We fix the soil so the seed can't grow.
Precisely. That is the shift, moving from hunching the seed to rehabilitating the soil.
That's a powerful image. And it makes me think about that final provocative thought we always like to leave our listeners with.
Well, consider this. We spend billions developing drugs to target specific mutations, the seed. We attack the tumor. But what if the host, your body's environment, is more important?
Go on.
If we can truly rejuvenate the host, restore the macrophages, clear the senescence, could we theoretically live with mutations that never actually turn into cancer?
You mean just carrying them around harmlessly?
Exactly. Could we render cancer impotent just by making the body a hostile environment for it? Could we coexist with mutations indefinitely if we just keep the house clean?
That is something to chew on. It changes the definition of a cure from eradication to containment.
It really does.
Listen, thank you so much for breaking this down. This was dense, but so fascinating. And to you, the learner, thanks for diving deep with us. Hopefully you're looking at your own maintenance systems a little differently now.
Take care of your architects.
Spot on. We'll catch you on the next deep dive.